Dr Kathryn, midwife, researcher and lecturer at King's College London. I'm delighted to share with you an upcoming event, a conference devoted to personalised maternity care on Wednesday, the 8th of June. Learning from current practice with birthing women and people's needs centred, we will explore how personalised maternity care can be facilitated. Safe care is personalised care. Therefore, to support the implementation of the immediate and essential actions, this programme will share insights from national, regional and individual trusts, as well as individual maternity practitioners. Sharing from all levels of the maternity system, this conference adopts a whole systems approach to making personalised care a reality for all. A must-attend programme for senior maternity and midwifery managers, clinicians, trust governors, risk managers, academics, researchers, regulators and safety and clinical excellence groups, as well as charities, all tasked with implementing improvement to maternity care in the UK. We look forward to seeing you there. Hello, my name is Dr Kathryn, midwife, researcher and lecturer at King's College London. I'm delighted to share with you an upcoming event, a conference devoted to personalised maternity care on Wednesday, the 8th of June.
Challenge to you is to join that effort. Let's not throw up our hands, and there are many people that throw up their hands, when it's time to roll up our sleeves, because years from now, this moment will pass, and our children and our grandchildren, if you haven't got children and grandchildren, your nieces, your nephews, your friends' children, will ask, where were you when the stakes were so high?
What I would say to people in relation to going forward in midwifery or in nursing, it's all about communication, collaboration, communication and negotiation.
The future. What would I like is for us to have national guidelines for pregnancy, labour, birth and postnatal care. Not for it to be itty-bitty throughout, no matter what area you're in, it's slightly different.
The impact that early losses were having on women and parents, and also in terms of the sort of wider family, friends, social networks of women and couples.
So I created a series of short videos of each of these technical skills here in the list, from handling the instruments to all the knots that they need to learn, and so the students could follow along and learn.
We know that when you have a healthy mother, you have a healthy infant. All of the research and data tells us so. So ensuring that mothers themselves have an adequate iron level is doing something for their children, but also for their future health, well-being and future pregnancies.
As one HCA said, the roles have significantly changed. We're now doing one-on-one care with patients. We're teaching patients. We're doing the baby baths, the demonstrations that cater for a class up to 20 people. We're teaching students now, and our whole role literally now is one-on-one. And it's not about what we're doing. We love what we're doing. It's about what we can't do.
The focus is on getting to a country where it's safe, where you feel safe, and then sometimes it comes about a few weeks later, sometimes months later, and when you're not surrounded by your social support, your friends, your family, these feelings of emotional distress can just manifest themselves at any given moment. And it's really important that as midwives that we engage with perinatal mental health support to help support this vulnerable group of women and birthing people.
The impact of bias and microaggressions is being recognised more and more often as a contributing factor to mothers and babies dying. Training to understand the rates of inequality for both women and babies and impact of bias needs to occur regularly for midwives and other healthcare professionals.
They're aware of the importance of the physiology, that actually the physiology of pregnancy, labour, birth and the early weeks after birth and breastfeeding prime the mother for mothering. They help in the health and well-being of the baby. They reduce pain. They give a sense of social openness. Oxytocin is the hormone of calm and connection. They know that science, but they actually can't put it into practice.
in the clinical areas. So we have a whole area of our science, which is at the foundation of midwifery, that is called a cult, that's called an ideology. And our work actually will be to put forward that science so that it's understood both a scientific basis and the importance to good care.
Thank you to you for everything that you have done in this space. We've had 2 years of a time that you never ever could have imagined, 2 years of a pandemic. Who could have imagined that we would have lived through something like this? But we have, you have, and I just want to say a huge thank you for everything that you have done.
And welcome from the Birmingham Edgbaston Centre. It's Tuesday at the moment, but for you it's Wednesday. And welcome to Maternity and Midwifery Hour. Really glad you've come this evening because you're going to get the edited highlights of what we've had today, which is absolutely fantastic. You don't get the exhibition and some of the other sessions, but you're going to have Being, Surviving and Thriving in Midwifery from Dr. Sally Pezaro. You're going to get Elizabeth Duff talking a little about postnatal care. And then finally, the icing on the cake will be Midwifery, Is There a Future for Us with Dr. Kathryn Gutteridge. And that is going to stimulate, challenge and inspire you. So enjoy, and I'll see you next week.
So first of all, how do we cope in challenging times, challenging inside and outside of midwifery? As Sue said, I'm a panellist in the Nursing and Midwifery Council, and the types of cases we see coming through often involve maladaptive coping strategies where people are using alcohol and other substances to cope. And of all the Nursing Midwifery Council Fitness to Practice cases, this is between 2014 and 2016, 16% related to alcohol and 10% related to drug use. So this is something we see quite frequently come up. I've had experience of it in practice, and also doing this research, people have come forward to me and told me their stories about how either themselves or their colleagues have struggled in practice with this. But if you look at the literature, it's largely dominated by experiences of care of physicians and nurses on this. As usual, midwives are lumped in with nurses, and we're not really looked at as an individual professional and how this might affect us. And the common findings we see in outside literature is really related to a lack of support, fear, stigma related to this, denial, unhealthy coping strategies, not knowing how to cope, obviously mental ill health associated with this, and the need for targeted workplace wellbeing interventions. And the stigmatizing perceptions that substance use is a personal choice or a failure or moral character, etc., which act as barriers to help seeking and aren't really helpful in themselves or true. And like I said, the data on midwives and nurses is often merged, but it has been looked at before in other professions. So first of all, when we started on this journey, in 2020, we did our own systematic review thinking about, well, what is out there on midwives? You know, if we're looking at the topic altogether, we only found 3 studies after doing a systematic review on this. So it really is limited. And the overarching themes we saw were, yes, there was, in relation to midwives, harmful daily drinking, and that was linked to working hours and harmful alcohol consumption, but it wasn't really looking at many other areas of substance use at all. And then in terms of student midwives, it was about escape avoidance, and then there was alcohol, tobacco and cannabis use. But the stuff on the student midwives was kind of related to student culture. You know, it's, you know, £5 night down the local pub in the student union. And so that binge drinking culture comes in with studenthood in general, rather than it being about linked to the profession. So we knew then that there really wasn't anything on this, but it was a real problem that was being highlighted by fitness to practice cases. So we decided to do some research on this, but there was a real ethical dilemma in doing so, as in I can't really say, hey, midwives, if you're experiencing problematic substance use, come and talk to me, because there's fitness practice issues related with that, and I would have to refer them to the nursing midwifery counsellors and fellow registered midwife. So we really needed anonymity and confidentiality to get people to talk about this and seek help. Impairment poses risks. We needed an amnesty to say, you know, if you come forward, you know, there's no consequences to you talking about this, because it's better that we know what the problems are and what we need to look at. So we decided we needed to move forward with this. No punitive actions, confidentiality, anonymity, you know, was the greatest benefit for it. So we published our ethical decision making in a paper there that we argued that this was needing to be done. So in 2020, we did our first study on this, and thank you to everybody who took part. We aim to capture self-reported occurrences of problematic substance use in midwives of the UK, and also what stopped them from seeking help, and what they thought about impaired midwives, either themselves or other people. So we had 623 NMC registered midwives surveyed anonymously, and we used the TAPS tool and the Perceptions of Nursing Impairment Inventory to as our measurement. So we changed nursing to midwifery. And our data collection was January 2020, and we had to stop it early because in March 2020 the lockdowns came in, and we thought, you know, with lockdown things are going to change quite dramatically, and we felt that might impede our data collection. So we stopped in March early. But we still got 623 midwives captured, taking forward, and we published our work in occupational medicine, and that's now published and ready to read if you want to look at the full findings. But our brief overview of findings was that just over a quarter of the sample screened positive for problematic substance use, and that was in relation to alcohol and a range of restricted drugs. It occurred reportedly in response to work-related stress, anxiety, bullying, traumatic clinical incidents, and the maintenance of overall functioning. So somebody taking too many sleeping tablets to recover from a night shift, etc. And 11% of those affected said they had sought help. 27% said they should seek help but did not, which is quite worrying. And the barriers to them seeking help included a fear of repercussions, shame, stigma, practicalities, and a perceived lack of support either available or they thought they didn't need it. And 10% of the sample said that they'd attended work under the influence of alcohol, and 6% under the influence of drugs other than tobacco or those prescribed to them. And 37% indicated concern about a colleague's substance use, so not themselves, but their colleagues. And the most perceptions on impairment were compassionate, which was really refreshing to see that people were very compassionate to other midwives in this situation. But there were a minority of really stigmatizing attitudes displayed, which is disappointing. And so the reasons for use, this is just a few of the reasons people said, midwives said they were trying to cope. Social stigma means I have to walk around my block late at night and I fear for my safety. Cannabis helps me relax. Following traumatic incident at work, I started using weed and booze to cope. Work is hard, it triggers my anxiety, I feel trapped. Escape from work stress, taking cannabis and cocaine. Bullying and blame culture in midwifery is rife. I use coke and dexamethasone to cope with hours of lack of sleep and having to function at work. So this is really heartbreaking, really. In terms of concern for colleagues, coping, midwives come on the early shift after heavy drinking the night before, shaking and impaired, trying to get through the shift. Colleagues addicted to alcohol, named and shamed by colleagues rather than helped and supported. They're bullied. Everyone else is looking on and learn from that. Now nobody asks for help, it's dangerous. So there's something there about if you see someone else treated poorly, you're less likely to seek help yourself. And midwives take cocaine to get through shifts. So this is kind of what was happening unspoken in practice. And then why help wasn't sought when needed. People said they felt trapped, they needed help, but if they sought help, they'd lose their registration or they'd lose their job. So they really felt like there was nowhere to go. I've seen others named and shamed rather than helped when they reach out for support. I can't afford to lose my job, my professional reputation. I struggle on. And then someone else, rather than helping her, she got sacked, named and shamed. It sends a very powerful message to others. If we need help, we get destroyed. No wonder we soldier on in silence. So this was the stuff that was going on that wasn't being resolved. And it was largely because of these stigmatizing attitudes that came through, where one midwife said, there's never an excuse. Midwives impaired by substances should be named and shamed, struck off and kept a low profile. We're a proud profession. As a senior midwife, I believe there's no room for weakness. One colleague was stealing drugs from work. She was suspended, and I made sure I told as many people as possible about it, including local and national newspapers. So that's really quite shocking there. And in my experience, midwives who've misused substances always play the mental health card once they've been found out. It's just an excuse for their own mistakes in most cases. So you can see why some people wouldn't seek help if they were faced with these attitudes in practice. But there were some majority compassionate attitudes, which is really refreshing. I believe abuse of alcohol is high. As nurses and midwives, there was no specific treatment programs aimed at them, unlike doctors and dentists who have, and they did not have to pay for. I applaud what you're doing. I'm really pleased that this kind of research is being carried out. There's far too much social stigma for midwives to feel empowered enough to address their issues / ask for help. So that's really encouraging there. And if we go on to surviving then, after that first study we did, we had obviously COVID and a number of lockdowns and a number of really stressful months, years of practice where things did change and everyone was put under pressure. And in the wider literature, people were talking about how health professionals might be surviving during this time by exacerbated substance use. People thought it would have increased in healthcare professionals during the pandemic. And the COVID pandemic has depleted frontline workers, where we know they do sometimes turn to maladaptive coping strategies in order to cope. So we thought, right, we need to do another study. We need to follow up our 2020 study with a 2021 study. And this was funded by the Ireland Trust. So very much grateful to them, very thankful for them for helping us to do this study and funding us. So 1 year on from the COVID-19 lockdown, the first lockdown, our aims were to identify the rate of problematic substance use again, to explore leaving intentions. So I know that this has been done while midwives leave. That study was done a few years ago. So we wanted an update on that following COVID. We wanted to explore the help-seeking behaviours of midwives. Are they more or less likely to seek help following COVID? And to identify the health risks and the work engagement of midwives. So how are they surviving? How are they coping following that lockdown period? So we plan to compare our data to those collected in 2021. And again, like I said, the Ireland Trust funded our study recruitment, so we were able to reach more people, although lots of people had survey fatigue, unfortunately. They still do. I do understand that. But they were able to give me media training as well, because I thought that the media would be highly interested in this, and I didn't want the media to take this down a road it shouldn't have gone down. I wanted the media to kind of look compassionately upon our results, and they funded in terms of alcohol, that 8.68 exact same people who are participating this time. There would have been some people participating in both the first and second times round, but really it was just from the same pool of people. So we can't talk about anything in terms of prevalence or anything like that. Try to bring her down years later. I tried to reach out to colleagues, but I was simply marched off the premises and treated like scum. They literally spat at me as I left and looked with disdain. They called me a substance abuser, which I found hurtful and unhelpful. I'm not an abuser, I am ill. And that's definitely how the NMC treat this issue, which is really refreshing to see. I used to have maybe a bottle of wine a week. Now I can easily have 3. I want wine. I wish I didn't feel like this, but I'm feeling tired, burnt out and unappreciated at work. I love my job, but now how the pressures of it make me feel. My family have noticed that I am moody and stressed, and I think I drink more often than I used to. And this is, again, I can't seek help as a registered professional. I am stealing and using drugs. I would lose my job, reputation and everything. So that the same issues were coming up, really. I've investigated midwives who indulge in substance abuse. They betray us all by stealing. They are drug abusers. There's no excuse. That's a stigmatizing perception there. And then I think about leaving, but I don't know what else I would do. I loved the job when things were good. So slight change there. And then in terms of people being likely to leave the midwifery profession, these were some of the reasons they said, and this is our early analysis. We've got more analysis to do, but the main reasons were retirement. We know there's lots of people about to retire from the profession. Really high rates of too much pressure. It's stressful. I've got poor mental health due to my job. Toxic work environment. So that's not just bullying, but people describing the workplace as being toxic, psychologically unsafe. There's a lack of career progression opportunities, lack of support. People's personal circumstances change, so they have caring responsibilities, etc. Major dissatisfaction with the quality and or type of care people were able to provide, so not being able to be the midwife you want to be, a recurrent theme there. Some people left the profession to get help for their substance use because they didn't feel they could get help and stay in the profession, which is quite sad. Dissatisfaction with staffing levels, the reason they're leaving, planned career change, lack of flexibility, perceived preservation of physical health. So if I don't leave, my back, I need to leave because my back problem will only get worse if I stay, that kind of thing. Bullying, feeling undervalued, and a lack of job satisfaction, which kind of ties in with the quality and or type of care able to provide. So like I said, these are our early kind of thinking in terms of the themes coming through, but we want to do more analysis there. And then people said, being a midwife is who I am, but I need to look elsewhere because the profession is destroying me. So they're leaving for those reasons. This is not a healthy profession to be in, not unless your face fits. Midwifery in itself is changing, feels like it's putting out fires rather than having time to truly care. And then someone said, I'm addicted to drugs. That's not compatible with an MC registration. I see no way I can get help without getting out the profession altogether. Now, that's really sad because we definitely have cases at the NMC where people have managed to get better and have managed to recover their fitness to practice and their ill health following situations like this. So I'd really like to do more work there in terms of people understanding that the NMC is really there to help. So let's talk about thriving, the last part of this this presentation. I didn't want to leave with kind of doom and gloom. I wanted to say, okay, so what can we do in order to improve things? What can we do about this? So be kind, obviously, is a big thing. Understand that we need to support each other and be kind to each other. And I also, with my esteemed colleagues last month in the Lancet wrote an article about midwives need a usable past to shape their future. There's recently been challenges to our standing as midwives through set reports and in the media all the time, really. And I said in the Lancet, conventionally, professions are granted autonomy and social recognition for the services they provide, but midwifery often lacks such status, which impedes our success. We're not respected in society, so that impedes us doing what we're really able to do. And I kind of made an analogy, you wouldn't tell a hairdresser that they didn't know how to cut hair. We're midwives, we know birth, we are the experts in that area and need respect for that. And a poorly articulated professional identity might have negative consequences and impact upon the recruitment and retention of midwives, because it's a determinant of our job satisfaction and sustainability of practice. So we really need that professional identity to be articulated well, and shape who we are. And it's just recently been the year of the nurse and the midwife, again, lumped together, nursing and midwifery, and it was on the centenary birthday of Florence Nightingale. So where's our kind of midwife hero, in our past? Where's our past shaping our future? And for midwives to be fully valued and play a crucial role in reducing global and maternal and neonatal deaths, their professional identity must be firmly instantiated. So that's definitely where we're going next with our research, thinking about how do we instantiate our own professional identity, put a stamp on who we are, and get society to mirror back that reciprocity in terms of valuing who we are, so that we feel less likely like we want to leave the profession, more like we want to stay and do our best and have that value firmly there. Also, myself and Dr Karen Mayer, who's an occupational psychologist, and she specialises in midwifery, which is really cool. And we're writing a book at the moment, and we are drawing in lots of different authors, lots of different perspectives on this, so we can help people to unearth their own identity as a midwife, who they are, occupational psychology tips on how to survive and thrive during the day-to-day challenges, respond to workplace challenges, and Karen was involved in all of this research throughout, and she's really been it's really been great to have that other perspective outside of midwifery to look at this, because she's helped us to write all these chapters on thriving in interpersonal relationships, surviving when things go wrong, surviving in evidence-based practice, and then there's stuff on leading with impact and turning your visions into practice. So it's a bit of a kind of self-help, surviving and thriving in midwifery, which we hope to have out next year. So that's something we're really putting all the research together and everything together to say, okay, now what can we do about this? And this is just another kind of off the cuff thing that I'm putting out there. I have a PhD studentship opportunity out at the moment. So again, we can survive and thrive in evidence-based practice. And this is linking evidence to our teaching. So if anyone's interested in doing a PhD, and trying to think about how we put our research and our evidence base into our educational teaching throughout our careers and within student midwives, there's that opportunity there. And then lastly, Midwives in Focus. We've brought together, I'm the project lead for Midwives in Focus, where we're really looking at how do we pull together midwives around the world. And we're doing this in partnership with JPIGO and Coventry University, but we're pulling in other stakeholders as well as we go. And you can see the steering committee there, to think about how do we pull everything together? How do we make sense of things? And doing that initial data check and data collection on professional identity. So, if you're a midwife or a nurse midwife, how does that affect your professional identity? And then everyone's talking about, strong midwifery leadership. That's what we need. That's what all the kind of reports are saying. Well, what does that look like? What does that mean? How do you know a leader is strong? How do you know that leadership is the best it can be? And how do you emulate it? And then we're also looking at representations of midwives around the world. So how do we want to be instantiated? How do we want to be represented? Who is our historical hero that we can have our own Florence Nightingale type character that we can hook our own professional identity onto and move away from being lumped in with nurses and really standing out on our own? So that's the work we're doing there. So there's lots going on. And I try to share as much as I can on social media and our blogs and everything. But as a last kind of thank you and goodbye, everything, could I ask that you complete our survey, which is a global call for all midwives and nurse midwives to share their ideas and experiences on their professional identity, strong midwifery leadership, and the representation of midwives around the world. And the link is there, and the QR code is there as well. Share this with all your colleagues if you have, especially if you have international midwifery connections, because we'd like to get as many people as possible to across the world to think about this and get our first data collection on this, so that we can take forward the work we want to do in terms of instantiating midwives and their professional identity, so that all of the things we're talking about, surviving and thriving and maladaptive coping, we can take forward in a positive way, and do something productive with that, and move forward towards actually instantiating midwives as they need to be.
I'm going to take you back nearly 300 years. This is, I think, a rather lovely etching which illustrates lying in after childbirth. Lying in now a rather outdated word, but in fact not so long ago we used to have hospitals called lying in hospitals for mothers giving birth and after birth. So there's some rather interesting things associated with this sort of illustration, and it starts bringing up some of the themes that I wanted to explore. Uncleanliness, not a word that we use much now, but I think from my previous story about the bodily fluids, we can understand what that is talking about. The Christian Bible, this is the Old Testament, I think it's the book of Leviticus, says that a mother is considered unclean for 40 days after having a boy and 80 days after giving birth to a girl. I'm not today going to explore that difference. I think it's quite interesting and I'd love to know more about it, but it's not the particular thing about it. What we do see is that the mother is rather secluded. She's in a curtained bed. She's being cared for by women. There is clearly a reference to a period of seclusion, and it looks as though probably the men in the community are not around there while she's considered unclean. So these are themes that I think will reoccur, and in fact quite a lot of words here, but you will see, and I have put a note here, these are the results of quite superficial research, to be honest. I have looked at other faiths, quite a few of the major faiths, but certainly not all in the world, and nearly all of them have references to uncleanliness or impurity, about a pollution period or seclusion period, about women visiting and caring for the new mother, more about uncleanliness, and in the Christian religion in Europe, the end of the line in postnatal period marked by a churching or blessing to mark the ends of the weeks of separation. It's quite common. In some cases, I believe in some Chinese traditional practice and elsewhere, the mother is not encouraged to wash, to have a shower, or even these days to have a shower or bath or wash her hair for quite some time, 4 or 6 weeks. I think the month is referred to in those cases. So there's quite a lot going on there right across the world, recognition of this period where women need care, they're kept apart, they're looked after by other women. Quick jump forward to present day. This is really just a note about the contrast of what is expected from some women in the present day. You might even say that to some people, the media, traditional and social, are a bit of a religion these days. Clearly, the Duchess of Cambridge, this is actually after the birth of her first baby, came out of hospital looking far from unclean, looking absolutely gorgeous in a new fashionable designer dress, with all these fashion details noted by Town and Country magazine at the time. She didn't look as though she was going to have a period of seclusion, and I don't know exactly who was going to look after her. I suspect she will have had medical caregivers, probably both male and female. So, bit of a modern take on it. We don't really know how the postnatal care went. She's doing fine, it would seem at the moment, but quite a contrast from 300 years back. This is some reporting from what happened. This is feedback that came to NCT, the charity that I work for parents, during the pandemic. And this again shows a different kind of contrast from what was happening. Women felt very alone, very isolated when they'd had their babies. They saw less of the health professionals that they expected to see. Midwives, health visitors, and GPs were overloaded with work, were encouraged to see women only by remote telephone or video connections. Some midwives and health visitors were deployed elsewhere, so taken away from postnatal care, again, because it's often seen as a less important part of the service. And particularly mothers commented that absence of conversations with peer groups or professionals left them unaware of what to expect in caring for themselves. I'm going to talk briefly about the Ockenden report, but I think just summing up the lessons from what I've said before is about follow-up on the risks in postnatal care. It so often doesn't happen because postnatal care is under-resourced and neglected, as we've heard, and there are so many things it can lead to that are really dangerous for mums and for babies. The Ockenden report came out finally a couple of weeks ago, I think now, and I'm sure you will all be aware of it. Most of the distressing and tragic stories were about incidents just before and around the births of babies, or very sadly, the loss of babies. But there were also sad stories about postnatal care, and I've just taken 2 paragraphs out of what Donna Ockenden wrote, because I think there are very key notes here. The sort of things that I've just been talking about, deterioration of the well-being of a postnatal mother, often signified by the body fluids, not in the normal spectrum, but abnormal, women feeling very vulnerable, women already at social disadvantage, suffering worse. Donna says, this leads to poor physical, social and emotional care provision. She talks overall, she says, postnatal care should be safe, supportive and compassionate. Of course it should, as all maternity care should. And overall, the report, as you will have heard, says listening to women is so important, and this needs to be improved in leadership and in culture of maternity care. As it happens, last month, the World Health Organization looked at this, well, as a result of a lot of work worldwide on postnatal care, and talks, interestingly, about a positive postnatal experience. It's not a phrase that we've tended to use, talked about birth as a positive experience, less so about postnatal, but I think this is a really important way of summing it up. Let's go back to Cinderella. We need to get her into that palace, and that is my acronym that says what needs to be done. We need postnatal action. We need leadership and accountability, absolutely supported by everything that comes out of, as has come out of the Ockenden report and elsewhere. We always need continuity, and I'm going to add culture and consistency to those C's. And of course, we need equity. Women at social disadvantage and clinical disadvantage need that care as much, if not more, than others.
Thank you, Sue. And this is the first time I've done an in-person event, actually, for a couple of years, like I imagine most of you. So it's really special, and it's nice because it's not too far from where I last practiced midwifery. So do know some of you here, I can see a few of you, and it's a little bit like catching up with old friends today. And I hope that carries on now. I hope we are not in the era where this will become, you know, almost like a once-a-year thing, because I think we took it for granted, didn't we, when we were able to go to conferences. And having done things on Zoom and Teams, what I said to Diane earlier is it's hard work on Zoom doing anything. It's a flat way of communicating. And the psychotherapist in me knows just how much it means to women and families having a midwife talking to you in the way that we do. So my closing session for you is is where we're at. And this midwife, Laura Godfrey-Isaacs, I don't know whether you've heard of Laura, but she does the journal, a journaling kind of, almost like a resource, a way of women and midwives working together to reflect experiences and to do some work with her. This picture struck me. This was in a lot of the press pictures, actually. Laura hasn't been a midwife that long, and I think she'd been 18 months in clinical practice when COVID hit. And next time I saw her was this picture, and I just thought, a mask is such a barrier in so many ways. We know that, don't we? We've experienced in theatres the way that a woman lying there flat on her back looking up and can only see masks and blue head pieces. It's a real barrier to feeling really hard about how that works. And some of the work that, whose shoes am I in? You know, the work of Jill out there that's done an awful lot in pushing forward how to personalise the patient journey. I think we've adopted quite a lot of that in maternity for the better. I also know there's research coming out now about delayed development in infants, particularly little boys, again. A lot of earlier research, way back pre-2000, around postnatal depression, picked up with little boys that mothers who were developing or postnatal depression held their babies in a different way. So they would hold their babies at arm's length in that way. It was very noted on some of the video observations that they did on mothers who'd been diagnosed. So the interaction with their little babies was distanced. And so, you know, if you have a baby and you bring it really close to you, the baby mimics very quickly and soon learns to smile, etc., grimace, all those things. I'm saying that due to mask wearing, that babies, particularly boys, are showing delayed signs of reaching milestones. And that's just babies. So what's it done for us as midwives? What's it done for us and our narrative with women? All right. I don't know whether you've ever seen this guy. You'll know him, Diane, won't you? He has done loads of jobs. He's been in loads of places. And the last time I saw him, he was being employed by a couple in Romania. Do you remember the case? And it was following this woman's journey, and he was going to be a midwife to have a baby at home because it was illegal to have a baby at home, and that was what she wanted. But what was interesting for me, because he's worked everywhere, probably more places than all of us put together, he said he thought the main thing we're facing at the moment, he was interviewed for the same article that Laura was, the previous midwife, is around the bullying culture, the hierarchical systems that are employed in maternity. This is his viewpoint on us here in the UK. And he says that that increases fear and anxiety in our profession. And I thought, boom, yeah. And he still wants to be a midwife. He still wants to work in the way that he was trained to do. But I think people like him have an outside view, that kind of almost bird's eye view of looking inwards to see what our problems are. And maybe we should be asking people like him to, where else have you worked and what have you seen? And how did that impact? And then, of course, We know about the reports, and they've come out less than a month ago, the last part 2 of Ockenden. But couldn't have been better time to put this programme on TV around the positive impact of being a midwife, so not just for our profession, but also on our society of which we live in. We need to do an awful lot of reassurance at the moment around what maternity is about, because there is a negative impact of everything that we've seen from the report, but also I believe in the mileage we made with Call the Midwife, which has been going now, is it 13 seasons? It's got to be. I mean, that transformed an awful lot of people's minds around, yes, it was back in the day, you know, it was probably pre-me being born, actually. But I was born in the era where babies were all born at home. And so I was born at home, and all my siblings were born at home. So for me, I understood that and knew that. But, you know, you move into the 70s and 80s, midwives of that era have not enjoyed that kind of exposure to normal birth in normal home settings with normal midwives doing their job. So I felt the timing of this is brilliant. And I've only watched one so far, but it gave me a nice fuzzy feeling of what I used to do and what I believe every midwife, if they wish, has the opportunity to do. So, you know, and I've got to mention the stuff, haven't I? I've got to talk a little bit about the Maternity Transformation Programme, because when Better Births was launched and we saw all the aspiration, well, it actually wasn't aspirations, it was proclamations of what was going to happen over a period of time. But then no one took into account, did they, of engaging with a national review team to go in and look at both Shropshire and Telford, but East Kent, which will be later. And then I just heard that a chair has been appointed for Nottingham. So we're going to have, over the next 18 months at least, bum, bum, bum. But I don't believe what we can have is this happening on and on and on, because there will never be implementation. There will never be embedding of solutions. There will always be recommendations with no implementation. The other thing that's worrying me at the moment is the interpretation of continuity of carer for personalised care, because that was a bit of a left field inclusion in that report. And I just was really interested why that should appear where it was, particularly stating we need to look at the evidence. The evidence is quite irrefutable if you look at it. And I've also done work with the Royal College of GPs, and they've got a platform called Personalisation of Care. And GPs have been working in both trial but also longer studies on long-term conditions now by the same GP seeing the same patient with a little network of people around them to address some of the admissions to hospital, the exposure to different treatment choices just because they saw a different person. And a piece of research was done with the King's Fund that showed a 10-year reduction in mortality if they'd had 2 years' worth of care. Now, I don't think you can argue with that. That, to me, is who's going to query that? That's irrefutable. So, personalisation of care with continuity is a healthcare, I think, basic. It's not a gold stamp. And then I want to look at this, which is a survey that was done recently, very recently, as you can see, 31st of March, looking at midwives and what they're thinking about at the moment in terms of their career. How do you feel about what you're doing? What's the pandemic done to you? What's it like working where you're working? And as you can see, it was conducted, it was last year, by the Picker Institute. And what they found across the whole of every maternity organisation was they were outliers for staff satisfaction and seeing themselves going. And it's in areas, but there is evidence of sharp declines in some of the key measures, which is recruitment, which is retention, which is sickness, long-term and short, because we know that there's different things for those, disputes at work, taking out grievances, all of those things were reported. And it says that it is likely that staffing shortages have contributed to that, but that's not the only thing. But I want to tell you about this. I've become very interested in this. And the way I became interested in post-truth, take midwifery out of it for a minute, is an interesting concept. And you know, I could talk a lot more about this, but I just want to introduce the idea to you here. Post-truth midwifery, I think midwives have been singled out in the media narrative. I think we have become an easy target. We are also a home birth midwife, or you're a labour ward midwife. And when we all know it's not as simple as that, we are so much more than that. We are either a normal birth or a medicalised birth. Trust and confidence from, and this is what the media tell us, from the public is low in midwives. I don't think that's true. I think they're confused because they're seeing one thing and yet on experience levels at their appointments, it's okay. I know morale is fluctuating. Some units, they're on a kind of level basis, but others, it's up and down. And there are reasons for that. But there's an undercurrent, I feel, of this rule and divide. Because what the media and other kind of powerful sources would like to think is we're against doctors, or we're against women, or we're against home birth. I'm guessing you know Leah Hazard, don't you, who wrote Hard Pushed, who was a journalist before she became a midwife. I mean, she's got a brilliant kind of way of articulating what we're all thinking. She put this tweet out recently, which is a steady stream of vitriol directed at midwives is a bunch of cruel, twisted gatekeepers. That's how we are being perceived. And she was really angry, and I don't blame her. So we're oftenly shown, as I said, in this complete spectrum of being, you know, beatic beings like the Mother of Christ attending, or this horrific person standing on us saying, you can't come in here, we don't want partners in here, so on and so forth. It's not that true. A simple view of midwifery and midwives does us no favours at all. It shortchanges the women too, because they will not use us as we are best intended to be used. I think, though, that there is this idea that it's women's work. And I see a man here before me today, and that gives me great hope. And I teach at the moment at a local university, and men come through. They come through because it's not about gender. It's about being a midwife. And for me, that's right. It's about coming to us for the right reasons. We get pigeonholed often, and I think that's gone on now quite a long time, about how dare midwives make decisions for a woman's care on their own? How dare you do a care plan without involving a doctor? I'm sorry, but you know, my rules, my standards, my education has given me the right to do that, and I am living and experiencing the job in the way that I should be doing for the benefit of women. So, I'd like to say, not all midwives are bad, and we're certainly not all mad. We're not in a cult, not that I'm aware of. We're not ideological beings. We base our beliefs and our experience and our education on science. It wasn't so much when I started, I can tell you that. And a few of you will know that back pre-university education, it was very much about the best we had at the time. But even then, we did anatomy and physiology. We did the science that we had. But so many brilliant midwives out there now are researchers who have done hard graft to give us what will take us to the next level. Anyone can be bad. Anyone. And we've seen it in healthcare. But I don't believe midwives as a group are bad or mad or come to work on a daily basis to do bad things. In any report of any service out there, and I guarantee you I could go to any unit at this moment, and I've done these visits where I've done observational critiques and I've done a service evaluation, I will find things that are wrong because that's how it is. But it's around about how open are you to hearing that and how open are you to moving yourself forward to involve the right people to make the correct steps going forward. So this is a little bit more about this post-truth thing. This is where I first got interested in it. I was part of the World Health Organization convention on postpartum hemorrhage, and it was convened with people from all over the world to look at the expertise around, well, it's all well and good in a hospital in the UK, where you've got access to products, people, so on. But actually in the third world, or sorry, not supposed to say that anymore, are we? We're supposed to say developing societies, etc. How do we ensure that they have equitable safety? And sometimes it's about giving the midwife a motorbike so that she can get where she needs to get quick enough. But at the time, the election for the next president was ongoing, and there was quite a lot of people there from the US, and I was saying to them, well, Trump will never get in, surely. Surely. And then what happened? Trump got in. So Trump got in, and the reason for this, and looking at, I've looked at lots of journalists' work on this, and lots of people who are interested in it, because of this post-truth thing. Now, what post-truth means is you construct a reality of your own by only involving people who will say the things you want to hear. And that's what the media are doing to us at the moment. There are certain people who are feeding the media the story of what maternity is and what midwives are. And the media are then, thank you, article there, Sunday Times there, what have you. That's all well and good. But actually there's another conversation that needs to be had, which is the truth, not the post-truth, the truth of being a midwife. And that's why I'm so pleased that the Yorkshire Midwife programme is on at the moment. So you have to almost tackle that spectrum out there of post-truth, because midwives work with obstetricians, that's our reality, and give that clear, almost non-controversial statement of, this is the team, this is how we are, this is going to work because he can do that, she can do this, I can do that, you can do that, and bringing it together. And I think we have to challenge this Trumpism of maternity by putting out really truthful, positive things about what the reality is of being a midwife today. And the reason he became so powerful and so almost like even when he didn't get in at the second attempt was because he mobilised his Twitter troops, and mobilised them, didn't he, by putting them into Capitol Hill and storming. And God forbid that we should have that happen here to us. But I just wanted to use that kind of analogy for you so you could see how these things work. I also wanted to give you a little bit of understanding about something that's really important at the moment, which is misogyny. Who has heard the issue about Angela Rayner in Parliament? How disgraceful is it that should even be out there, that she's using crossing and uncrossing her legs to put the Prime Minister off his speech? I mean, God forbid. But look at this. This was said in 1970 by Barbara Seaman. She said, actually, we're seen as women as diseases. The menopause is a disease to be fixed. Pregnancy is a disease to be managed and fixed. Even contraception is something to be fixed. Well, when you start to look at us as a gender then, and I use gender because men can identify in a more feminist gender than masculine, that's their choice. That then you start to see we've got a big, big, deep-rooted misunderstanding about womanhood, and that affects us in our work as midwives. What has been exposed, and although I've seen some issues around this, is investment and underinvestment and under-resourcing. Because we've had report after report after different government after different government, but what we've never seen is a breakdown to the absolute penny of what maternity costs for good care in this country. We've never seen it. It's been a block contract. There you are. Thank you very much. Go on and do it. And everyone then interprets doing it in a different way. But I guarantee you it'll all be menu-led or service-led provision. It won't be woman-centred upwards. Because the menu says, this is what we've got today and that's what you can have. And if we don't get proper investment and resourced correctly, then no matter what we do, whatever recommendations we put in place, it will never change. What we need is we need people to stand up to bullying, and we need to have our own voices here and to take our own destiny forward. Because we're not the subservient group of people that I think the media would like to portray us as, we are advocates, autonomous, and clinically competent. And most of the time, clinically confident, except when people keep battering us. So we need strong leaders who are not afraid to speak out. We need to work in a way that our training's provided for us to do. We need to be respected as well. I will not tolerate people saying bad things about midwives. I will report them. I will write a letter. And I will also involve people in government if I have to. I want to work closely with other people around me, but not for them to tell me what to do, for us to agree what to do. And I want women to be confident, to have meaningful conversations with us about what works for them. And I want every single midwife to be proud. I know my husband said to me a few weeks ago when we were watching night after night, because we get the Midlands TV in our area, I bet you're embarrassed and ashamed, aren't you, to be a midwife? I said, no, I'm not. Because we're the solution. There might have been a problem, but it wasn't just midwives that were the problem. It's much more complex than that. So, there's a blog going out today, tonight, tomorrow that I've written. And this guy's always been one of my kind of inspiring people I look to for a few words of what to say. Do you know who that is? Yeah. So your lives begin to end when you become silent. And if ever any of you have been in a position where you couldn't speak out, you'll know what that means. I don't want you to be silent. I want you to be banging drums. And this was another thing I picked up last week. This was really shocking, and it was actually upsetting to see it, so that's why I put trigger warning up there. But you know what's going on in Ukraine. And you know there's been reports about raping women, children. This group of women here from Estonia stood outside the Russian embassy in Tallinn, naked from the waist down, with painted blood running down their legs as a protest about what was happening. And I thought, you don't need words for that, do you? Now, I'm not suggesting for a minute we go and do anything halfway near dramatic as that. But sometimes, look at that picture. It represents such passion and spirit between those women who are affected. But I'm saying this has got to stop. This has got to be an ending. And then another kind of aspirational comment, really, about standing together. I've said this many, many times. Those of you who know me will have heard me say, we don't need doctors or anyone else to attack us and to become our enemies, because more often than not, midwives do it to each other. If there's ever a time to put your shoulder next to your midwife colleague, now is the time. It really is. So I'm saying, is there a future for us? There's more than a future for you, because babies will still come into this world. And babies deserve, in our heritage here, to be in the hands of midwives to do that, because I know what it takes to become a midwife. You are strong. You chose a profession. For whatever reason, I guarantee you will have known that it wasn't going to be easy. You knew people would query your choice of career pathway. You knew that when you got home after doing an awful shift and a long day, and you couldn't even speak about it, that you'd go back tomorrow. You knew that. And you knew during the pandemic that this was exceptional and require you to make sacrifices, and you did. I am saying to you now, you know, just as a humble midwife, I'm proud that I chose to be a midwife. I have been silenced in the past. I have been bullied and exposed, both on social media recently and beyond that. But it will not quieten me, because I believe in what we do. And I know those of you that stayed here right to the end will go out, and some of this will just tick over a little bit and hopefully give you that thing that we as humans have, which is hope. Animals don't have that, we do. And as dear old Sheila, and all of you will know Sheila, said, in all cultures, the midwife's place is on the threshold of life. It's where intense human emotions, fear, hope, longing, triumph, and the incredible physical power enable a new human being to emerge. This vocation is absolutely unique. And I know it's not just about that moment of birth. For me, it was always bigger than that. It was always in the culmination of seeing a mother born. Because she births her baby, but we see a mother born. And for me, that is the beauty of midwifery. So, yes, there is hope. Yes, there is a future. But remember what is said. There's never been a time more important to put your shoulder next to that midwife, that student midwife, that doula, even that obstetrician next to you, and to really go forward and to make this profession everything we want it to be and we know it can be. Thank you.
My name is Dr Claire Feely, midwife, researcher and lecturer at King's College London. I'm delighted to share with you an upcoming event, a conference devoted to personalised maternity care on Wednesday the 8th of June. Learning from current practice with birthing women and people's needs centred, we will explore how personalised maternity care can be facilitated. Safe care is personalised care. Therefore, to support the implementation of the immediate and essential actions, this programme will share insights from national, regional and individual trusts, as well as individual maternity practitioners. Sharing from all levels of the maternity system, this conference adopts a whole systems approach to making personalised care a reality for all. A must-attend programme for senior maternity and midwifery managers, clinicians, trust governors, risk managers, academics, researchers, regulators and safety and clinical excellence groups, as well as charities, all tasked with implementing improvement to maternity care in the UK. We look forward to seeing you there.